Hello and welcome to the Spine Nerve Podcast. My name is Dr. Brian Hovez.
And I'm Dr. Jason Kung.
And we would like to thank everybody for paying attention, listening, and tuning in to our show, to the podcast. We have over 100,000 downloads, 1,000 subscribers on YouTube. Really do appreciate everybody taking the time to share and to send this to your colleagues that you think that this is interesting or something that they can learn from. Really does mean the world to us. Hopefully as we start to, evolve the podcast and find more ways to be able to bring you value, you guys keep continuing to share and continuing to reach out to us to let us know ways that we can help. But today, Dr. Kung, what are we going to be discussing?
I wanted to just go over some things related to epidural steroid injections, their safety, and going over a little bit about anticoagulation, just kind of as a refresher, because it's always good to stay on top of these. There's always lots of new medications out there, whether we should hold them or not hold them. So I thought it was good to go over this again.
Yeah, I think a refresher on the anticoagulation guidelines and, always thinking about what those risks are for our procedures always makes sense because, obviously the first thing that we want to do is make sure that we're mitigating those risks as best as possible.
Yeah, I think it's also important because, sometimes we leave it up to the PCP to decide whether the patient should stop a medication or not. And personally, it seems like if we're the ones doing the procedure, we should understand first, the risks of the procedure and them being on or not being on a medication. But I think we should also understand why these patients are on the blood thinners, the antiplatelets, anticoagulants in the first place. And I think really, the interventional pain physician should be the one making the call.
Yeah, no,
in most cases, not for everyone, obviously. But.
Yeah, obviously there are complicated patients, patients who are working with cardiologists and very specific in terms of how the cardiologist thinks that their anticoagulation is necessary. But yeah, for sure, understanding why they're on it, whether it's primary prevention or actual treatment, et cetera, really helps us to manage all of those risks. Not to get ahead of the gun, but because when we think about things like that kind of large study that came out of Australia a few years ago, right, where they're thinking about stopping anticoagulants versus not stopping anticoagulants, and we actually saw that there were more adverse events with stopping the anticoagulants than with doing without. So we always have to make sure that what we're doing is the best thing for the patient, not just to make us feel better that they're off of their blood thinners.
Right. Yeah, I was I was reading the Pain Physician Journal a few months ago, and there was a letter to the editor from, I think, the June issue from a Dr. Naeem Haider over on the East Coast. And he was just, him and his team looked at the various Anesthesia Quality Institute closed claims database reports of complications from epidural steroid injections. So, it kind of piqued my interest just because patients always ask me, most commonly, how long does it last? When does it start to take effect? But then usually the second or third thing is how risky is it? So I thought it was good to just look over this and just re-educate myself and hopefully update everybody. But so as a review, this closed claims database is basically a database where any sort of adverse events related to anesthesia is reported. So it's about 9,000 claims as of 2011. It started in the mid 80s. So of those 9,000, they also include the complications from epidural steroid injections. It's the most common procedure that interventional pain docs do. I found this stat just staggering. I don't want to just stat overload. There's going to be a lot of stats here, but 9 million epidural steroid injections on an annual basis. 9 million. I mean,
wow.
So that's a lot.
Oh, right.
What's that?
You do about 1 million of them yourself?
Yes. Yeah, so that's just a lot of epidural steroids. So you would think with all those injections, there's bound to be a lot of complications. So how many are there? So the author and his team looked at the data set specifically between 2011 and 2013, just because of the Some of the cases after 2014 were still in the process of closing and being entered into the database. So the really solid set was looking at between 2011 and 13. So that's 3 years. And they found a total of 21 claims for adverse events from epidural steroid injections. So actually it's 21 claims, 3 years, 7 claims a year. That's actually about a if you do the math out, it's a 1 in 780,000 chance of a adverse event, serious enough to be entered into the closed claims database. So I found that number to be reassuring, at least from my own knowledge, that any major serious morbidity and mortality issue is actually quite low with epidural steroid injections. I think from anyone that does these on a regular basis, the most common complications that we see are sometimes patients will have a vasovagal event or increased pain, it didn't work, or some procedural pain from the epidurals. Do you see any other more common adverse events, I would say, Brian?
I mean, I think those are obviously the most common ones we see. Those are ones that probably people see, let's say, out in the community, probably on a monthly basis or so. You kind of will have somebody vasovagal or report some increased pain afterwards. Obviously, as we step up to the slightly more rare, we start thinking about things with post-oral puncture headaches or things along those lines.
Right.
But yeah,
right.
I mean, I agree. I mean, the number, being essentially pretty darn close to 1 in a million chance of having an adverse event was worthy of being put into this database. It's a pretty impressive number. I mean, I usually tell patients that it's exceedingly rare for something significant to happen. Just go through some of those more common things. I don't think I've ever actually truly believed that if I would say 1 in a million, that it would be relevant.
Right.
I mean, it's
and the author also found that as far as neurological issues relating to epidurals, that was about 10 cases, and that of those 10, about half of those were some sort of spinal cord trauma, 20% being epidural hematomas, and then the other 30% being infection or an abscess. I found this interesting is that about half of those 10 cases were actually seen in the cervical spine, and then with the remaining 30% in the thoracic and lumbar. So once again, the cervical spine epidural space is much smaller compared to the thoracic and lumbar area. So any sort of issue is much more apparent. I was even reading something that you can even have these asymptomatic epidural hematomas that can happen, and patients will have no symptoms from it.
Yeah.
But supposedly in the thoracic and lumbar area, but if that same amount of blood were to pool in the epidural space in the cervical spine, that could lead to some major issues.
Yeah, no, definitely. I mean, obviously, when any of us that have looked at an MRI, you can tell just looking at that canal, right? And particularly if you're in the lumbar spine and the lower lumbar spine, like most of the epidurals are done in a lot more space for any of that fluid of any kind to be able to dissipate around and not compress and cause real problems.
Yeah, so I think that just the takeaway from that, what I got from that letter to the editor, is that they're very safe, and probably because of the various societies coming together, forming these quite specific anticoagulation guidelines. In addition to that, the avoidance of deep sedation for epidurals, the use of non-particulate steroids, that's kind of argued, and then also the use of fluoroscopic guidance has just made epidurals much safer over the years. I did find some case reports of some other adverse events that I just thought I would share those because I found those interesting. There have been descriptions of epidural hematomas for patients undergoing interlaminar ESIs in patients that aren't taking any anticoagulants. So it can happen even if you're not on a blood thinner. It can happen if someone's on aspirin for, it looks like this patient was on secondary prophylaxis for a history of MI, patient had epidural hematoma. And even if you hold some of the anticoagulants for an adequate amount of time, this one case described an hematoma in a cervical epidural in a patient that was holding Plavix for at least 7 days before. So, these things can also, unfortunately, can happen. but we do our best to try to avoid it. I also found this very interesting one that wasn't related to a procedure at all. It was a case report in 2019, and it was a 29-year-old that presented to the ER with a 2-week history of back pain and right leg radiculitis pain. So the docs thought that it was probably a L5 radiculitis. He had diminished light touch and pinprick on the right leg. He had no cauda equina symptoms whatsoever, but his history was notable that he was taking really high doses of naproxen, so 500 milligrams every 4 hours for about 2 days. He had no family history of abnormal bleeding, no personal history of abnormal bleeding, not taking any anticoagulants. Labs were all normal, platelets were normal, and the MRI showed he had a subacute hematoma between L4 and L5. Thankfully, this patient underwent decompression and basically had complete resolution of his pain, but I thought that with even not having any sort of instrumentation in the epidural space, it can happen.
Yeah, that's a pretty wild case.
Yeah.
And unfortunately, I mean, 500 milligrams of naproxen every 4 hours for a couple of days isn't all that abnormal to hear. Right? I mean, it's not like the patient's just gobbling the entire bottle of medication. It's obviously it's above what most of us would recommend, but that's not an unheard of amount of medication that I think a lot of us will hear from patients when they have an acute flare.
Yeah, so that kind of segues us into just going over the ASRA guidelines. I'm not going to go, I don't think we need to go specifically into the details of aspirin, Plavix, Eliquis, and how long to hold it.
We'll link the actual guidelines in the show notes so that if you haven't seen them, then you can kind of take a look at them and be aware.
Mm-hmm. And there's also a handy app that you can download that you can punch in the medication, you can select the procedure, and it gives you basically a nice format of looking it up quickly. But I want to look at just kind of how this came about. So from the first few pages of the guidelines, the authors basically did a survey at the ASRA meeting in 2012. So 124 docs that were there and participated for the survey, and I found that almost 100%, like 98%, followed the ASRA guidelines for anticoagulants. But interestingly, 67% had separate protocols for aspirin and NSAIDs. 55% stopped aspirin before SCS trials and implants. 32% stopped aspirin before epidurals. So because of that kind of homogeneous distribution, that prompted ASRA to work on these specific guidelines for interventional pain procedures, and that's the one that came out in 2018. They have a nice little checklist at the end, just as a refresher for anyone scheduling somebody for a procedure. So they kind of list it out as first, you look at the patient's specific risk factors, the physical exam and chart review, and look at any family history of bleeding issues. I found this one interesting. So physical exam, you're looking for signs of easy bruising, petechiae, mucosal bleeding, ecchymoses. When I see a patient that's on a blood thinner and I'm thinking about doing a procedure that I typically wouldn't hold the blood thinner for, but I see that the patient says, "Oh, I bruise really easily," and you see all the spots, on their arms. I always hesitate a little bit about continuing them on the blood thinner. What about you?
Yeah, I mean, I think we see this often with especially some of our elderly patients, right, where they just have that kind of very kind of classic elderly bruised pattern on their arms. Yeah, I mean, I think it does make it pay a little bit more attention, right? That they're very light trauma, presumably is what causes it, right? So bumping against furniture or just while doing their normal activities, that nobody would really consider trauma as causing bruising. I mean, I think it's only normal to try to think a little bit harder about, okay, well, this person's also on an anticoagulant. Is this all the anticoagulant, or is it there's some just inherent, their
Right.
clotting factors maybe just aren't quite what they once were, kind of thing.
Right. And that kind of leads into the next part of the checklist, is to basically look for any other systemic signs that the patient may have a coagulopathy. So we're looking at any sort of renal or hepatic disease, check to see if they have any relevant labs or coagulation studies, ordering them if you feel that it needs to be done. And then also just looking to see what other anticoagulations, or if they're on any anticoagulation medications at all, as well as aspirin or NSAIDs. Then, just to look at, if patients are on aspirin, I think, a lot of folks are on aspirin, either for primary prophylaxis or for secondary prophylaxis. So if they've had some sort of cardiovascular or cerebrovascular event in the past, that will be secondary prophylaxis. That also kind of weighs into my, if I were to hold it usually for a procedure, but I know that the patient's had strokes or heart attacks in the past and has been recommended to take aspirin, sometimes I will continue it for that. But it's always a patient-specific decision.
Yeah.
So then it's just the next part is informed decision making, involving the procedural physician, PCP, and the patients, and understanding how the drugs work, how they're eliminated, how long it takes for them to get out of your system. There are some other drugs that may also alter coagulation. To be honest, I haven't read the guidelines in a while, but towards the end of it, they mentioned some of these other medications, like even SSRIs can theoretically affect platelets. I believe it's platelet activation, but it didn't seem like that it's really clinically relevant. So I'm not really aware of anyone holding someone's SSRI for a procedure. Have you heard of that before?
No, I have not.
Yeah.
But I mean, that review that Azra did, I think, was one of the most expensive ones that I think I've ever read.
Yeah.
I remember reading that as a fellow, and the one that I remember being in there is garlic.
Garlic and ginkgo biloba. Yeah.
And so, I mean, because I remember, going through it as a fellow, and you obviously you pay attention to the major ones that people are prescribing, especially in your area, right? I mean, obviously, prescribing trends are different, and so where some patients, some areas are going to be high on Pradaxa, others are going to be high on Effient or something along those lines. I'm going through and I'm like, oh, look at these. I mean, just the depth to which they cover things, like including. Like I said, garlic always stands out because I remember, like, the first time reading that, I was like, huh, that was a unexpected one to find in this paper. But yeah, I mean, obviously, I think most of those things are, have things that you have to take into account, but aren't necessarily the most clinically relevant for the vast majority of patients. Right? Yeah,
I think for me, for those other kind of medications that are not thought of commonly, or herbal remedies, it just reminds me to just ask. It's a quick question: do you take any herbal supplements? And if I find a patient, it's, I'm taking high doses of garlic because of X, Y, and Z recommendation. We're planning to do a spinal cord stimulator implant or something, or a trial. Maybe I would say, maybe hold off on that for a week or so and continue it afterwards. I don't see a high risk of stopping that, but it just keeps. Don't forget history and physical. Very important. The next step here is basically look at the anatomical location of whatever intervention that you're deciding to do for the patients, considering that it may be slightly higher risk of procedures in the cervical spine versus the thoracic or lumbar sacral area. Categorizing them from high, intermediate to low risk procedures. Then looking at your imaging, right? Very important. It's whatever you have, whether it's CT, MRI, X-rays, any prior surgical intervention. And then after all of that, making the final decision about whether you want to hold something or continue it. And if you are to continue it, to really clearly explain your thought process as to why you think the risks outweigh the benefits for that particular patient, for that particular procedure. And then monitoring the patients. We always like to check in with patients, not only to see if the procedure worked, but if it didn't work, but also to have something at least on the books to make sure that we can catch any sort of adverse event that may be developing that the patient didn't feel that was appropriate to call us or inform us about.
Yeah, I mean, I think, one of the things that, we learn in fellowship, and that I hope that most people continue on, is having that follow-up portion, right? Because obviously, you got to learn the indications and how to do the procedure right. But, the most important thing afterwards is making sure that we're following them appropriately to ensure that their safety has been met, right? Not just, we do the procedure and we feel good about it in that moment. So having that follow-up, a few days to a week later to be able to make sure that you're watching that, and then obviously to, ensure that the patients are responding the way we want to. But, that safety component, I think, is such a big component that I could see how that would easily fall out in practice as people are trying to figure out how to keep up with patient demands and keep up seeing enough patients to help their communities.
And fellowship, we would rotate with different attendings almost every single day. So you work with one, you do some procedures with them, and you don't necessarily even follow up with the patient. So coming into practice now, it's been pretty gratifying, but also nice to know that we're also monitoring these folks afterwards, keeping track, in case anything strange were to occur, that they have something on scheduled so that we could talk about it. So I mean, that's kind of the gist of it. Just looking, once again, we didn't go into specifically about how long to hold these medications for, but it's really just a reminder for folks to just take a look at it again if you haven't in a while. You might learn something new, and to always stay vigilant, even though we may, everyone gets comfortable and gets, anecdotally it hasn't happened to them. But these procedures, while they're very, very safe, do carry a risk, and we shouldn't forget about that.
Yeah. And so just to kind of finish up, maybe I do think it's always worthwhile to bring up the other side, right? And so the Andrews study from 2017, which I referenced earlier, and we'll once again also note that in the show notes, is the one that looked at continuing versus discontinuing anticoagulation. And so in their population, it was mostly looking at patients that were on Coumadin or other kind of stronger, clopidogrel type antithrombotics. And in their study, they actually did not have a large number of patients that had complications with continuing the medications, but they did have a fair number. I want to say a number, but I'm probably going to get the number wrong when thinking off the top of my head. But I think it was about 8 patients in their study that, with stopping their anticoagulation, they actually had some type of thrombotic event. And I do remember specifically, medial branch blocks, transfemoral epidural steroid injections, sacroiliac joint injections had 0 complications as far as bleeding within their patient population, which was pretty extensive. There was over 1,000 patients in each of those subgroups for each procedure that underwent one of those injections on full anticoagulation with no bleeding complications. And, so I mean, when we're thinking about this and when we're analyzing the risks for our patients, I mean, obviously, thinking about the bleeding risks and with that amazing data that you quoted that's been recently published, thinking about the essentially 1 in almost 1 million chance of a bleed, and then which maybe also kind of negates a little bit of that study. But I mean, patients on full anticoagulation, they have over 1,000 patients that underwent some of these procedures on things like Plavix and Coumadin that had no bleeding complications afterwards. I mean, I think it is pretty good data to say just how safe this is, and just makes us have to think about how we want to make sure that obviously protecting the patients as best as we can from the things that we're doing to them, but also making sure that we're thinking about the patient holistically and saying, okay, well, what's overall the best thing for this patient, knowing that for these certain procedures, particularly for like, a medial branch block or a sacroiliac joint injection. I know at this point, I rarely hold anticoagulation for those procedures.
Yeah.
And so, I think thinking about all of those things for the patient, because there is an inherent risk of coming off of their anticoagulation that we do have to take into account, because like you said, at the end of the day, we can't just say that it's their primary care doctor's job to manage all of these things. We know the risk. Like, there's not going to be a primary care doctor that is going to be aware that there was a study that showed 1,000 patients on full anticoagulation underwent transfemoral epidural steroid injections, and there was 0 complications, right? And so those are the things that we have to be able to bring in the picture, and at least educate the patients, right? I mean, obviously, if the patient's like, what, I really don't want to take a risk of bleeding or something along those lines, or the other way, right? I don't want to take a risk of having a stroke again or something like that.
Information is power. Yeah, as long as everyone's informed, whether it's us, hopefully, definitely us, and also the patients, right? That would be, it just leads to better outcomes for everybody. Shared decision making. Everyone's taking ownership in their care, and it just makes it so that the system works much better. But just a review of something that's been out for almost 5 years now, but always good to refresh myself with some of this data.
Oh, absolutely. Well, thanks for bringing in those studies. I appreciate it. I think, like I said, I think that data that you presented from the anesthesia data set from 2011 to 2013 is pretty awesome. I think when you presented it to our group yesterday, I was really impressed by seeing that study. So I think it's good to have that, and then kind of rolling through all of this. It's hopefully people learn and can kind of get something valuable out of it.
Yeah.
All right, everybody. Well, thank you guys for listening. Reach out to Dr. Kung. Tell him he did a fantastic job at presenting our study today. And please, once again, if you found this valuable, please share it with your co-fellows, co-residents, and co-medical students. And we'll continue to be here to help you guys along the way. All right. Stay tuned for those legal disclaimers, and we will talk to you next week.